start there.
Because first of all, today's the 13th anniversary of the ACA.
You mentioned it, yes.
We should acknowledge that. And yeah, absolutely. That was a tremendous amount of effort pre-ACA, stand-up, covered California, of course, as an exchange, and then did this massive expansion of Medi-Cal. And really, we should finish the job. We are very close to realizing something that probably everyone in this room has worked on over the years, which is we need to get everybody covered. And we are very close to that. The governor has a proposal on the table. The legislature, I suspect, is just trying to figure out how fast can we do that. But there's also work to do. We have people who are eligible who aren't enrolled. We have people who are eligible for subsidies and don't use them. But nonetheless, we should get to universal coverage, and that is in our foreseeable reach. We have the leadership to do it, we have the know-how to do it, and I think coverage is, we should finish the job with coverage. Coverage isn't, it's necessary, but it isn't adequate to, of course, get us to the health outcomes we want, but it absolutely needs to be done, and again, COVID, who's in, who's not, who's got a primary care doc, who's got a medical home, how do we know who got vaccinated and who didn't? I mean, all of those things. If everybody were in the system, we would be so much better prepared. And frankly, our delivery system would function so much better if that were the case.
And cost, per capita cost would probably drop as well.
So, affordability is a real issue.
We know that from your survey. It's one of the top 3 issues among Colorado or Californians.
That's right, and now we
probably
have
Coloradans
and now,
too.
Yeah, that's true. And now we're the legislature and the administration is getting ready to stand up an office of affordability, healthcare affordability. One of the challenges that we have, obviously, is transparency on costs. What do we pay for? What gets cross-subsidized? How does cost and quality, what's the nexus there? There's a lot of negotiation about how much we're going to share or not. But I think we're headed in the right direction.
Some people don't really have different understandings of what transparency means. When you say transparency...
Yeah, I'm sort of referring to, both what do we pay for a particular treatment or treatment episode. But I'm also talking about our overall cost of care trend. And we have costs embedded in our system in all sorts of places. And really understanding that, we know there's a lot of inefficiencies in our system for which there are costs associated with them. We refer to that as, sort of the frictional costs of repeating tests and repeating this and repeating that. So I think we want to have better data about hospital costs and where they're spent. We should get better data from really all of our systems. And it I think increasingly ought to be tied to quality and how people perceive their care to be received as well.
Well, quality, you mentioned quality. I'm just wondering how we can move forward on quality. Quality requires data, requires a lot of big investment in kind of information systems, and identifying what the proper measures are and finding ways to incentivize them. Anything to...
Well, I would name a couple of things in that. For the first time, I think, in our effort at getting better at really naming measures that are important for the delivery system to aim at. Covered California and CalPERS and Medi-Cal have agreed together as the public purchasing entities in the state to name 4 measures that all of those plans and providers under those plans need to aim at for the state. Those were very carefully thought about. Covered California actually now has incentives built into the contracts for the plans that are going to participate in Covered California. Medi-Cal has a very large initiative that they are building out. Those measures are noted. And they're measures that have been measured over a long period of time, but a delivery system looking up at multiple purchasers and multiple networks with different priorities, it's very difficult for a delivery system to say, okay, these are the things that we're going to work on. So childhood immunizations, hypertension, hemoglobin A1C, and colon cancer screening. And if you look at the data, it's very solid data, covered California used. And CHCF helped provide some of the backbone for that data. And I think it's important for us to sort of name, when we're talking about quality, what are the measures that have the most impact on large populations, for which we have, childhood immunizations we know how to do. And by the way, we lost a lot of ground during the pandemic. So that's the measures piece. And I think public agencies coming together and saying these are the things that are important is super important, because, again, you've got plans and delivery systems that work in all of those systems, and aiming all of our public efforts in the same direction, I think, is helpful. And then the other piece that you mentioned is data. Yeah. And I would argue that, we have to do all of the things we've talked about: CalAIM, expansion, the interface between public health, community-based services, emergency services. You really do have to have a data exchange infrastructure that allows for real-time exchange of information. And there's a stakeholder group working on that today. Many use cases you can imagine coming out of that. We collect data everywhere, but the sharing of it in a useful way for individuals that are trying to navigate our healthcare systems, it creates silos. On top of the financing silos that we have great silos of data that do not really benefit the care delivery, the health outcomes, or the disparities that we're trying to address. So standing up a data exchange framework in the state, creating the regulations, the incentives, the penalties, the rules that govern it, getting rid of the conflict of interest that is associated there. I think that is a pillar for really any of the policy agenda that we have as a state of California. And I think it's a super important opportunity.
Well, on the policy agenda right now, the big one seems to be CalAIM, and I want to get to that in just a second. But while we're still talking about data and that sort of thing, there's a whole issue of disparities and equity in healthcare. And you all have done some work focusing on that. An issue for me for a long time was on maternal and child health and infant mortality and that sort of thing. And that's one place where the disparities really do show up.
Yes.
Any thoughts on that area?
You're absolutely correct. Black maternal mortality is one of the starkest disparities. It's been true since I was in medical school, so call that 35 years. And it has not changed since then. And CHCF is working in this space. We, again, many leaders in the state of California in delivery systems, nurses, doulas, midwives, are advising California Healthcare Foundation about ways into that very stark disparity.
Yeah, no, you're so right. That is an issue. Way back, you talk about 4 decades ago. Once upon a time, I chaired the Maternal and Child Advisory Committee of the federal government for 14 years. And this was an issue that was just a nut we couldn't crack. Not just reducing the level of infant mortality and maternal mortality, but the disparities, which seem to persist over time. Is there anything that shows up there that would be the next opportunity to improve in that area?
I you know, this is an area where implicit bias, where our over-reliance on acute care facilities for deliveries, but also, you know, the extent to which culturally we begin to address some of the racially driven components to these disparities really do compel us, I think, in workforce to draw a workforce in that reflects the population that we're trying to serve.
Yeah, that's kind of a long-term strategy.
But we've had this long-term disparity, right? And so, you know, some of this is implicit bias. A lot of this is, I mean, literature on pain. You know, we're now talking about big data sets, and if you use artificial intelligence to be able to make decisions, and you've got embedded in that racial biases, then those decisions are going to continue to perpetuate kind of the racial issues that exist today. And so I think there's a lot of work to be done to draw people into a workforce that come with lived experiences and that begins to change the delivery system from the inside out.
Is there anything else to cover before we get to CalAIM?
CalAIM could take the rest of the afternoon.
Okay. All right. So this major initiative to kind of take Medi-Cal to the next level with CalAIM. So many opportunities there. So when you see that, what is it that we're going to learn? What are the biggest challenges? Where do we go with CalAIM?
Yeah, so you know, one of the things about California is we do tend to build on what we've learned. So the precursor for this work was whole person care. And there, you know, again, data was super important. In fact, if you ask counties that did really incredible work in whole person cares leading up into CalAIM, the data exchange, the sharing of information between behavioral health and physical health. We haven't talked about behavioral health. That's certainly another area worth talking a little bit about. Community-based services. That's fantastic that we now will be able to give plans to be able to opt into to community-based services. You and I were talking a little while ago, you know, during the early days of the HIV epidemic.
Yes, which you were very much part of.
Yeah, we created community alternatives to hospitalizations. That was the goal.
I mean, you were in San Francisco Health Department
during the AIDS epidemic.
During that period of time.
That's right. And I guess I would name a few things that are relevant as we think about CalAIM, and particularly community-based services. And that is that, first of all, the urgency during the HIV epidemic was much like the urgency we saw during COVID. And I think the urgency that we have today as we continue to put more people into Medi-Cal is to sort of say, how do we actually make a system out of organizations that philanthropy funds in fits and starts. They have often weak infrastructures and yet are very trusted in communities. And provide valuable services that now under Medi-Cal will be able to be reimbursed. And there's just a host of technical and very logistical technical assistance that needs to be able to make that a reality. Plans have to learn to work with those organizations. Those organizations have to learn simple things like how do you build a plan? How do we get free-flowing information there? How do we make ease of eligibility there? So I think that's certainly one piece. In lieu of services is huge. I think, you know, one of the biggest challenges facing California, bar none, are the number of people who are unsheltered and unhoused. The opportunity that we have to really think about how we create services in CalAIM that recognizes that you can't have health care or better outcomes for people who have comorbid conditions, whatever those might be, if they're unsheltered. And so there's a huge amount of opportunity there. And by the way, many other component parts that are trying to come into affordability of housing and those kinds of issues. But fundamentally, look, if you think back to the day when we said we're going to deinstitutionalize folks with serious mental illness and create community alternatives.
Yep.
Well, we got rid of all those beds, and we never built a system of care to serve that population. And I think that CalAIM fundamentally gives us an opportunity to redress that very serious policy mistake that was made many decades ago.
Yeah, well, one of the aspects of CalAIM is the integration of care. It's like adding integration to cost, quality, and access. So now that we have this integration of care, and behavioral health is kind of like phase one or priority one to kind of integrate with physical health. So many opportunities there.
There are many opportunities there, for sure. Look, I think if you look at the data, and you look at people who have a serious mental illness, and then you look at their risk of coronary artery disease or just their overall mortality risk, much more likely to die earlier, whether you have diabetes or coronary artery disease or any other comorbid condition, and vice versa is also true. And we created silos of the way that we built delivery systems. When somebody has a delusional episode or a psychotic episode and they're in their 20s, is this a one-time issue? Is this the manifestation of a serious mental illness? Should this be taken care of in the county? Should this be taken care of by a health plan? That whole maze has not served the patient population, our families, our communities well at all. And we have had many pilots across the state of ways to better address that integration in particular. And by the way, one of the, I think one of the silver linings that comes out of the pandemic is I don't think people whisper behavioral health or mental illness anymore. I think it is a mainstream issue. As you've had your kids at home or your parents at home or you're working at home, all of those stressors were super apparent. And so I think in many ways we've destigmatized mental health by virtue of coming out of a pandemic. And I think that should benefit us as we think about the delivery of services and the integration of care between mental health, substance use disorders, and physical health. I think that as families experience those, if we listen to their input, we will build a more integrated, no wrong door access point.
Yeah. I mean, it is interesting how discussion of mental health issues has really come out in the open as more folks have acknowledged it. I think a survey in 2019 said about 20% of persons acknowledged a mental health kind of issue. And by the end of 2021, it was 43%. What a difference. And even, in the popular press, Prince Harry said, when you start talking about mental health struggles, was the word he used, you discover you're in a very large club. And so I think that's one of the, I guess it's a benefit of the pandemic that has
Well, we did a survey actually just before the pandemic, CHCF did, and at that time, the most important issue was access to mental health and behavioral health. And that was before the pandemic.
Yes.
And so I think that it is now, there was hardly a session today where the issue of behavioral health and the workforce we need for behavioral health didn't come up. The governor has a very big proposal on trying to start early in behavioral health and wellness and try to link the delivery system to schools. That is two massive systems to try to bring together. But I think we've destigmatized it, and that should help us, I think, as we try to scale better integration programs, primary care in some of our county clinics, and really just thinking about how we use telehealth to get better reach into expansion of our delivery system.
Yeah, I mean, all of the things that are under the umbrella of social determinants, of them, the first one that comes to my mind is housing. And there are some, I mean, every state learns from every other state in terms of how to go forward. There's another state, Arizona, that integrated housing into health plans some years ago. And now the Medicaid agency in Arizona, which they call Access, is the third largest housing agency in the state of Arizona. So that might be part of the path that California is going on now.
The governor, when he was the mayor in San Francisco, even then, very interested in delivery models. And there was, a lot of expansion of supportive housing that occurred under his mayoral term. And if you look at what it takes to finance that kind of service, what you quickly realize is you're trying to braid all sorts of different funding together. And here we are now again coming out of a pandemic where we quickly tried to put people into housing and get folks off the street. This was before we had vaccines. CHCF is now doing an evaluation of those programs to sort of say, what can we learn from those that can better inform this very question and the opportunities that exist within CalAIM.
Yeah, so you talk about you're doing a survey now. What are the issues you're seeing in the time we got left? I just want to kind of focus here, into the future. So what are the issues that you're seeing in the future that you want to look at, or that you're looking at now, or that your current work kind of informs?
Well, look, I think that, okay, we're going to get everybody covered. Let's finish that job. Then I think the question is, what is the network capability and capacity for delivering high quality, timely care? So that involves accountability. And what are the ways in which we're going to begin to hold plans and providers accountable for that? And so I think that is super important. And fundamentally, you can't talk about quality without sort of saying, what are the health equity measures that we are going to want to see 5 years from now and 10 years from now? And that requires that we collect data differently, that we analyze data differently. And it requires that we not think about quality in one place and health equity in another, but really build those systems together. And I think, accountability for, I was telling you, we started Medi-Cal managed care, I don't know how many years ago. We've decided that plans are our way. And, Covered California had a meeting where we asked the plans to come talk about how's it's going on all of these quality measures. And what I would say is we have a lot of work to do. We have a lot of work to do. And so, many good people working in the plans trying to figure out exactly how we're going to do that. We need a delivery system that doesn't think necessarily as we are the safety net system per se, but we are the mainstream system, and we are a mainstream system that's going to deliver on the promise of health equity. And I think this is a state that can do that. I mean, we've been on this universal coverage journey for some time, and I think that's the challenge before us.
And if California can do it, it can be done anywhere.
Well, we believe that to be true.
It is such a big, complex state where achieving these kinds of major system changes is maybe even more difficult than it is some other states. Anything else that you'd like to kind of share about the work or its impact and direction on health policy?
Well, look, we have an administration that cares about healthcare and has made a lot of, the waivers, the work to get the waivers done. And so in some ways, the policy work is nearing completion. Mm-hmm. The implementation and execution is really the next leg of the work. And that really rests in a lot of delivery system reform. We train people in verticals. We pay people in verticals. And so we have an administration who cares about the issue. We have significant revenues in the state to be able to make these kinds of investments. We have a lot of examples of programs that have worked that, but for scale, would have dramatic impact on certain populations, in particular, populations that have multiple chronic conditions and live in low-income communities and the like, and have a lot of social issues that determine their outcomes. But I see it as a lot of policy alignment, a lot of opportunity with the resources that we have, and coming off the pandemic, a recognition really that I think compels all of us to think about how we, whether we're CHCF or we're a plan or we're a hospital or we're a clinic, how do we lean into this extraordinary opportunity? We told our board, the policy work that we've been at for many years is really nearing the finish line in many ways. Now, how do we regulate it and how do we execute it? And how do we make sure that consumers have access to us as we are working these programs out? We won't get them all right off the bat, and I think the importance for us is to make sure that we keep a consumer voice. We have great consumer advocates who've helped us get this far, and we have great models for that kind of public accountability, and I think that's one of the things that will make these programs successful. So,
right. And the promise of that in terms of the health of all of California is, it makes it all worth the effort.
Absolutely, absolutely.
Thank you so much for taking the time today. What a great conversation. I really appreciate it.
Appreciate it.